everyone, and welcome to today's PHO webinar presentation. Don't know where to start? Try an organizational risk assessment. My name is Melissa Miller, and I am an infection prevention and control specialist here at Public Health Ontario. Joining me today as co-moderator is Lori Schatzler, a fellow IPAC specialist, also with Public Health Ontario. We are both thrilled to serve as moderators for today's session. The land on which I live and work is what is known as Barrie, Ontario, is on the traditional territories occupied by the Anishinaabeg people. The Anishinaabeg include the Ottawa, Ojibwe, and the Potawatomi nations, which are collectively known as the Three Fires Confederacy. Having grown up in Barrie, Ontario, I recognize that for several generations, this land has a rich history of being home to diverse Indigenous communities and now home to many First Nations, Inuit, and Métis peoples. As we reflect on the National 2024 Infection Prevention and Control Week with the theme of Prevent with Intent, I ask that you join me to acknowledge the wisdom and contributions these Indigenous communities have represented in our history across our lands, and also to show our gratitude and commit to reconciliation and supporting positive change. It is now my pleasure to introduce the speaker for today's presentation, Rohit Garg. Rohit Garg is an IPAC specialist who has been working at Public Health Ontario since 2014. Rohit is a foreign medical graduate with a master's in public health from Yale University and has been continuously certified in infection control since 2010. He is a member of IPAC Canada and has been on the executive committee of its GTA chapter for the last 7 years. Rohit also holds a green belt in Lean Six Sigma and has a special interest in quality improvement in IPAC. Prior to joining PHO, Rohit supervised the regional epidemiology program at the New York State Department of Health and has served as director of the epidemiology and IPAC department at Staten Island University Hospital in New York. I will now pass things over to Rohit.
Thank you, Melissa. Good afternoon, everyone, and I wish you all a happy National Infection Prevention and Control Week. So again, topic of today's presentation is don't know where to start? Try an organizational risk assessment. Let me begin by presenting a couple of scenarios imagined from the time when the COVID-19 pandemic started. Scenario A, nurse calls infection control team. We have a patient with respiratory symptoms who recently returned from a country experiencing an outbreak of a novel respiratory virus. We immediately triage them to a private room with contact and droplet precautions in place. Everyone is wearing a full PPE with N95 and a respiratory virus panel testing, including COVID-19, has been requested. Anything else? Now the scenario B. Nurse calls infection control and says, we have a patient with respiratory symptoms sitting in the waiting room for an hour. Going to give them a mask now. We don't have any private room available. I don't know what to do. I don't want to get COVID-19. I have little ones at home. So which of the two scenarios sound familiar to you? Which one you would like to be in? I bet it's the first one. If there's one thing we all learned from the COVID-19 pandemic is that we are not fully prepared to deal with the emerging pathogens. The pandemic also highlighted the importance of establishing robust IPAC programs to promote the safety of our staff, residents, clients, and for operational efficiency. With that, we hope that by the end of this session, participants will be able to outline the key components of an effective infection prevention control program, ensuring an understanding of the foundational elements and their practical application, comprehend the role of organizational risk assessment in healthcare settings, and follow the steps involved in conducting a thorough ORA. Access and leverage Public Health Ontario resources to effectively guide the ORA process, ensuring you have practical tools and guidelines at your disposal. Throughout the presentation, I will be saying the word ORA, which is short for Organizational Risk Assessment. Hope that is all right with you. Now let's do a quick poll to see what types of setting has our audience joined us today. So on your screen, you will be seeing a poll, and that asks you a simple question: what sector do you work in? And we have listed all sorts of factors that we can think about. But if none of these is the setting where you belong, please select others. And for a better viewing experience, feel free to enlarge your screen or hover your mouse over the polling questions and response options when they come up. All right, so we have some results in, and I do see we have a lot of people joining us today from long-term care. We do have folks from acute care as well as public health. So welcome you all today, and I hope you all benefit in this presentation. So for those who may not know or want to refresh, IPAC program is a comprehensive and organized set of activities within the healthcare settings with the main goal of protecting patients, residents, clients, and staff from getting sick and passing that on to someone else. These goals are relevant to care activities not only across the spectrum of healthcare settings that include acute care, long-term care homes, clinical settings, but also to the non-healthcare congregate settings such as shelters and group homes. So everyone joining today will benefit from this presentation. A question you may ask now, so what makes it an effective IPAC program? The components of an effective IPAC program, as shown in this image, going from left to right, include IPAC training for healthcare staff on IPAC practices, providing them with timely updates on new guidelines and protocols to ensure adherence to safety measures, developing, routinely updating policies and procedures based on the current regulations and best practices, providing a supportive physical environment, such as having private rooms or spacing the beds if it is a shared room, maintaining air quality, etc. Then ensuring material resources such as the items of personal protective equipment, alcohol-based hand rubs, and cleaning supplies are all available where and when needed. Surveillance, which is the monitoring and tracking of infection rates to timely detect outbreaks and identify areas for improvement. And finally, support from the leadership in creating a culture that promotes IPAC best practices throughout the organization. Whether you are trying to reduce your infection rates of antibiotic resistant organisms or improving staff compliance with hand hygiene or preventing severe outbreaks from happening, all these components are important. Furthermore, IPAC program need to be based on a continuous quality improvement approach where the processes and outcomes are continuously reviewed and improved. Having said all that, managing an IPAC program can be challenging when faced with limited resources and multiple priorities. To overcome these challenges, it's prudent to optimize your IPAC program. That's when the organizational risk assessment helps in prioritizing the needs of your IPAC program. This will not only reduce the workload for your staff, but also ensure adherence to established guidelines and best practices. So what is this ORA I'm talking about? It is a systematic approach to identify potential internal and external infection risks in order to implement controls to mitigate the transmission of infections in healthcare settings. The Organizational Risk Assessment, or ORA in short, provides a framework for the components of an IPAC program, not only for those who don't have an IPAC plan and don't know where to start, but also help those who have one by evaluating existing IPAC measures to assess their effectiveness. ORA is important as it forms a strong foundation on which your IPAC program is built. And this leads to prevention of healthcare associated infections, improved patient and staff safety, compliance with regulatory standards, resource optimization, customized infection control strategies specific to your setting, effective emergency preparedness, and many more. So let's do another quick poll to see how aware you already are about this organizational risk assessment. Again, for a better viewing experience, you may want to enlarge your screen if it is currently in a short version. So the question up front in front of your screen is, what is your level of experience with performing or supporting an infection control ORA? You have to pick one choice. Do you consider yourself an expert, have done many? You have done some and participated in a few, or this is your first time listening to hear this, and that's why you are joining us today. Okay, we have the results here. So I see a lot of people we have here today have some experience, and quite a few number would like to know what it is all about. So good that we are hosting this webinar today. So let's not waste time. Let's go right into it. How is this ORA conducted? Presented here is a simplified 5-step process of an ORA. ORA can be little time consuming, therefore, at the minimum, it should be conducted annually or frequently as the need arises. For example, when there is a threat of a pandemic or your local epidemiology data suggest high transmission risk period for certain infections, and when I say that, I'm indicating mostly ARIs. Step one is to identify risks. Who can be exposed and how can they be exposed? Think about the sources of infections, services your staff provide, and the environment in which they are provided. Then the step two is to analyze those risks. Are there any contributing factors that increase that risk, enhance them? These can be internal to your organization or external. For example, high community transmission of acute respiratory infections. Similarly, are there any control measures that may reduce this risk? For example, active screening of staff and visitors for infectious symptoms may prevent the disease from entering your facility in the first place. Step three is to assess that risk. What is the likelihood of that risk from happening, and how severe the impact will be if it happens? This step helps in prioritizing the risk and helps you determine which action needs to be taken first. I would say this is the most important step. Step four is now managing those risks based on the priorities identified. Are there any regulatory requirements or best practices available to us that we can use to control or mitigate this risk? Can existing control measures be improved? We don't have to place a new one, we just need to improve the existing ones. Step five is the final step of developing an action plan. How strategies and control measures identified in step four will be implemented. Basically, this feeds all into your IPAC plan for the year. Let's now do a deeper dive in this whole process. So for conducting an ORA, there is some preparation work that needs to be done to establish context specific to your organization. This way, you end with your very own personalized IPAC plan based on your own priorities. Here are some questions to get you looking at your organization. These are pulled from 2 PHO resources, one from long-term care and one from primary care, and they are referenced at the bottom of this slide. Where is your setting located? Is it rural or more urban? Are you a long-term care attached to a hospital or in a small community? That can affect your supports for your services and IPAC program. If you work in a home care or a paramedic, you may cover many areas. Or for example, if your community has a lower rate of COVID vaccination, that might impact what you do. What services do you provide? Foot care services, safe injection site? Is it community care to children with complex needs? Procedures that generate aerosols? There are some services that pose higher risks with certain due to certain factors. What population do you serve? Some attributes of that population: vulnerable populations such as elderly or children with complex needs, marginalized or people with the mental health conditions, chronic conditions, immunocompromised. What kind of population do you serve? Do you have an IPAC program? Yes or no? If you don't have one, starting it could be your first step. What about your policies? Are they current? Why does this matter? If they are old, then they do reflect current best practices. That's a question you may want to ask. Are you training staff on incorrect information? So that's something you may want to update them. Do you work with your local public health unit? Do you know what their expectations are? Many healthcare settings have been short-staffed. If you continue to be, how do you get things done so that everyone stays safe? The other part of the preparation is gathering data. The more data you have, the better your ORA will be. But you may need to work with what is available. Review your past infection rates. These are actual rates if you have surveillance program in place, or can be informal if you are a non-healthcare congregate living setting and do not have any kind of established IPAC program. You can think about like we had 3 or 4 clients sick with influenza, or they had been diagnosed with MRSA in a month. There has been history of staff exposures. Look into occupational illnesses. What were your experiences with the past outbreaks? How many people got sick? How prolonged it was? And all sorts of information. Review their staff training records. Results from audits such as hand hygiene, PPE, environmental cleaning. All of this information will help you in formulating your organizational risk assessment plan. What if a lot of these are not available? For example, no one has been auditing hand hygiene or environmental cleaning in the past. Then this might be the part of your priority when planning, doing some measurements first to see if there is a problem or not. Do you have the past inspection reports, such as from Ministry of Labor or local public health unit for reprocessing or food services? If you are an accredited organization, does that accreditation body has their own recommendations that you need to look at? So there is so much you can gather at the table before starting to actually look into the risks. Now, this is a very important slide because I want to stress on the fact that IPAC program should not feel alone. Like it is not the sole responsibility of IPAC individuals or the team, but you need to involve other departments and work in collaboration with them. In bigger organizations with the IPAC teams and those who have committees for everything, it might be easier just to set up a team from different disciplines. However, for smaller organizations, such as non-healthcare congregate living settings or a smaller long-term care home, individuals may reach out to key people within their organization, different departments, or even externally to help them in conducting this ORA. Example of external partners are listed here. They can be your local public health unit. It could be us, Public Health Ontario, IPAC specialist. IPAC hubs are great support to you now, and peers from similar settings. So now that you have gathered some data, have a planning team, let's now talk about how to identify risk. That is our step number 1. I hope everyone remembers the chain of transmission from your IPAC training modules. You may have taken some IPAC training from Public Health Ontario website. This is a simple model to explain how infections are transmitted from reservoir to a susceptible host. As you can see, the transmission occurs when viable germs colonize or grow in a reservoir, such as in people, animals, food, or water, exit that source through a portal. That could be nose, mouth when sneezing, transmit through air or contact, which can be direct or indirect or both, and enters through the portals of susceptible person to make them eventually sick or colonize them further. So think about all your activities area by area of your organization and ask yourself that the activity can transmit germs or not. With that understanding about how the germs can be transmitted, we can categorize the infection transmission risk as risk due to failure of staff performing IPAC activities such as hand hygiene, use of PPE as recommended, risk due to failure of cleaning and disinfecting shared equipments or surfaces, risks that are present in certain clinical areas due to the types of interactions and procedures that take place there. Certain procedures have higher risk than the others. Your physical built environment, such as the shared rooms versus private room, may have a risk of transmission between the residents and clients in those rooms. There can be risk due to specific infections such as clostriditis, difficile, MRSA, or others based on your patient or resident population. Now, step 2 is once you have identified your risk, it is time to analyze them. In this step, you actually weigh each risk by the factors that may enhance them or existing measures in place that may reduce them. Examples of such contributing factors can be high community transmission rates of infections, low immunization rates, that could be in your patient population you serve or your staff members, a high staff turnover. All these are hindrance for following best practices, and they contribute and increase your risk. Now, the examples of certain IPAC measures that you may have in place that may reduce the risk can be high staff adherence to IPAC practices, which is very good, or high immunization rate. So you have to kind of balance out your risk. What are the factors that are increasing it and what are the factors that may control it? Now, moving on to step 3, we now assess each of these risks that we have identified. We want to see how likelihood is for that risk to occur and what would be its impact if it does occur. For example, if hand hygiene compliance rate is low, that could lead to transmission of AROs in your vulnerable population, causing high mortality, then you assign it a high level of priority. So for the risks with high likelihood and high impact, you assign them a high priority that would require immediate action. For risk that either have a high likelihood or severity, but not both together, you may assign them a medium priority level that you will make efforts to further reduce the risk. Last but not least, be a low level of priority. When the risks have both been low likelihood and low severity, in that case, you can monitor those for now and reduce when feasible. So another factor you may want to consider when looking at the impact piece of this assessment is to see if there's a risk due to failure to comply with regulations or standards, because that might put you in trouble. At your multidisciplinary team meeting, you need to have consensus when assigning these levels, and these levels can change as you identify more risk throughout your process. You identify more high-level priorities, then the other goes down. So it is not a concrete process that is defined. It is more subjective and unique to your own setting. Now, I would say identifying risks and assessing them is only half the battle won. Now you would need to manage those risks based on their priorities. Remember, high risks need immediate action. In this step, you develop smaller goals and objectives specific to your setting to manage those risks. Use multiple strategies when thinking about control measures. Remember, we talked about IPAC components, that image with a lot of components. That can be used when planning strategies to manage your risk. I am sure you may have heard about the SMART goals. Otherwise, this is the picture on the screen. These are specific, measurable, achievable, realistic, and timely goals. So you create goals to manage your risk that is suited to your organization. Now, listed here are types of control measures or strategies you may use when trying to address a risk. They sort of align with the IPAC components that we talked at the beginning. Starting with the highest and most effective controls, and we often label them as hierarchy of controls. We can think about elimination as the topmost uh, control measure. Are there ways to avoid getting the germs in the first place? And we can certainly promote immunization because it removes the susceptibility, it makes people immune. So that is for sure a good way. Looking into your engineering controls, if we can we make small modifications or improvements to make it more supportive to IPAC best practices? Then there are administrative controls, which is looking into your policies, looking into the training of your staff on IPAC practices, and conducting IPAC audits. Lastly, are there things that staff need to do at their level when they are in certain clinical environment or interacting with their patients, residents, clients, such as wearing recommended PPE based on their point of care risk assessment? These are some examples of work practices here, like hand hygiene, cleaning protocols, safe injection practices that can be considered. Now, knowing what needs to be improved or put into place is not enough. It needs to have an implementation plan based on your organization's unique characteristics. Make sure you have all the objectives stated to meet the goal to reduce or mitigate the risk. As previously mentioned, these goals need to be time bound. Ensure responsibilities for each step are clearly assigned. Assign indicators to measure change, monitor, and periodically evaluate those indicators to check if the change is occurring in the desired direction and there are no unwanted outcomes. Equally important, which most of us sometimes not do, is to share this feedback with the staff and leadership. It encourages everyone to keep doing the right things. So now I will present a few setting-specific scenarios to help you further understand this whole ORA process. Let's look at this acute care scenario. An ICP at an acute care facility reviews last year's surveillance data and identifies an increase in central line associated bloodstream infections, in short called CLABSIs, in their medical unit. So the identified risk is high rates of CLABSIs in their medical unit. Analyses revealed improper catheter maintenance protocols is contributing to this increase. When assessing this risk, the ICP considered high number of patients with the central line and a high impact due to high morbidity and mortality from CLABSIs. So ICP decides to place this risk at high priority. So ICP now sets up a goal to reduce these CLABSIs by 70% over next 6 months. I guess they're quite confident that it will happen. Reinforcing training on catheter insertion care. So these are some of the control measures they thought if they achieve, then it will help reduce this risk. Implementing stricter hand hygiene, conducting audits of central line insertion, and maintenance practices. So there can be additional control measures. I'm just presenting a few to give you an example. Implementation plan. Now, it is important that, ICP works together with the clinical educator if they have one and a few nurse champions on the unit, and they would review protocols and also update them if needed. So this collaboration will help them to not only provide training, also for auditing purposes and on the spot feedbacks when needed. So the outcome of all this organizational risk assessment and the plan they created was that there was a significant reduction in infection rates within 6 months. So now let's move on to a scenario for clinical office setting. An IPAC designate at a clinic during their walkthrough in waiting area identified these risks. And this example I have taken straight from the document that we have published on our website. I will show that later. Patients can be exposed to infectious droplets of other patients with acute respiratory infections through droplet and contact transmission. Remember that chain of transmission diagram that we showed earlier? So that's how they determine this risk. Now, they also have non-immune patients that come to their clinic. They can be exposed to the respiratory particles from a case of measles through an airborne route. So when they analyze this risk, what they find is they consider there is a peak respiratory illness season, so there's more likelihood. There's increase in number of measles cases also seen in the community. The clinic sees both the elderly and pediatric patients, so that's quite vulnerable. Many children in the community are not up to date with their immunizations and limited physical space. So when you consider all these, you think there's a very high chance that, the transmission will occur and its impact will be severe. So control measures in place, they only have alcohol-based hand rub and medical mask available at the entrance. So the person conducting an ORA, they assess that, this is a busy clinic with the patients that often includes walk-ins. The number of respiratory illnesses and measles cases are on the rise in the community. The likelihood of the transmission is therefore high. Elderly patients with the weakened immune system may get very sick if they contract ARI, so the impact of this risk is also high. Now, the priority based on these arguments, overall level of risk of transmission is high and will require immediate attention. Now, managing risks in clinical office setting, installing a physical barrier at the reception, you implement screening everyone for communicable disease symptoms, posting signage for hand hygiene, masking, and respiratory etiquettes, immediately sending the infectious patient to the exam room, and if possible, using a separate exit after they are seen, scheduling preventive maintenance of the ventilation system, increasing fresh air ventilation, or use portable air filtration. So all these are some control measures for the clinic that can be utilized to reduce that risk. So now in terms of implementation plan, it includes more specific information how we will accomplish all that. So clinical office manager or healthcare provider develops a screening policy and questionnaire for staff to follow when booking patients, consulting with public health or professional association if a standard screening questionnaire or signage are available, checking with standards, Canadian Standard Association and short CSA, and best practice recommendation for installing physical barrier or portable air filtration or what level of air exchange is needed. Periodically auditing documentation is also important to ensure all the patients are screened according to what was decided. Contact building maintenance team or professional regarding the ventilation system preventive maintenance. So all these measures will can be time bound, how much time realistic they can be accomplished by whom. Now, the third scenario we have is about the organizational risk assessment in long-term care homes. This is, I just created a fake name, the Excel Senior Living facility recently expanded from 80 to 120 residents. With the increased population, the Infection Prevention and Control Team conducts an ORA to address potential risks from the facility's daily operations. So I know this can be tedious in this case, but it's important that we do this risk assessment process in this situation. So what did the infection control person determine was that there is increased resident density. Higher risks of infection can happen in shared spaces such as dining halls, recreational areas. Environmental factors can be that there are strain on cleaning services, leading to contaminated surfaces because everyone is overworked. Staffing level, again, overworked staff may not strictly follow hand hygiene and PPE protocols. There might be some lapses in some of the cases. Medication management, Potential overuse of antibiotics increasing antimicrobial resistant risk. So any of this thing can happen, and probably even more. So you have to identify all the risks. Now, analyzing those risks, in the past, your home or your organization saw that you had bad experiences with gastrointestinal or respiratory outbreaks, and that was mainly due to staff's poor adherence to hand hygiene and clinical cleaning practice. And you always had staff shortages. Now, existing control measures or favorable factors you have are that hand hygiene and cleaning policies and procedures are at least up to date. There's fantastic leadership support that supports your IPAC program. Now, assessing this risk likelihood, when we have people in close quarters, there's insufficient cleaning, that raises the likelihood of infection spreading. Impact: poor infection control practices could result in respiratory and gastrointestinal infections, and we always get vulnerable population, and these people need a lot of care. So that may be highly that can have a bad outcome on this population. So impact is high. So this we would set up as high priority, and what we set up as high priority is surface contamination in common areas and inconsistent hand hygiene by staff. So as you can see, we kind of keep refining our priority statements as we move along this process. Now, what would be the medium priority is overuse of antibiotics and insufficient staffing. So I think we are not discounting on these importance of these activities that we need to do. We need to definitely address those, but first and foremost, high priority is to eliminate surface contamination. How we manage this? The ICP actually decided that we will focus on cleaning protocols. We will train the staff, increase cleaning frequency, audit cleaning processes. Then we'll look into hand hygiene, install hand sanitizer stations, and monitor compliance. Staffing, we will, in the meantime, adjust shifts or hire additional staff to manage the increased workload. And you recall that the good thing about this home was that they had a very supportive senior leadership. So I'm sure that they will help you work out this. Antibiotic stewardship, educate healthcare staff on proper antibiotic use. So now the ICP or the person responsible for IPAC develops an implementation plan. What they do is cleaning protocols. They provide joint training with the environmental services manager and plan the frequency of the cleaning audits. Then for hand hygiene, they walk through the home, identify point of care locations to install ABHRs. They conduct hand hygiene refresher training for 100% of the staff over next year. Auditing staff hand hygiene with support from the champions. Again, you always need to work as a team with the other people as much as possible you can find. Staffing, seeking support from unit managers and home leadership to make some investment in that area. Antibiotic stewardship, reach out to PHO for audit tools and resources to educate healthcare staff on judicious use of antibiotics. So in some cases, you may not have a full plan right now, but at least part of the plan can be reaching out to those who may have those tools and information. So the outcome in this long-term care home is proactive risk mitigation, improves infection prevention and control healthcare associated infections, ensuring the safety of both resident and staff in expanded facilities. So we are feeling more safer now. So conducting an ORA can be challenging due to a variety of factors such as limited resources, resistance to change, lack of data for risk analysis, or other competing priorities in healthcare settings. Some of these challenges may have a solution, such as engaging leadership and staff from the beginning. Make them a part of the process, tell them benefits of this ORA. Building a culture of safety and continuous improvement and leveraging technology for monitoring. For example, there are now apps that can be used for conducting audits and programs that can help with the surveillance. So look around for solutions that will help remove your challenges. In this last segment of my presentation, I will now go over a few resources from Public Health Ontario that can support you with your ORA process. In case some of you aren't familiar with the best practices document, listed here are some of those, and these are developed by PIDAC, which is short for Provincial Infectious Diseases Advisory Committee. While while these are foundational documents, PIDAC and PHO also produce interim guidance documents, FAQs, fact sheets to support implementation of specific program areas. These documents are good to look at when you are at the step for managing your risk. So we have information on a variety of topics, as you see on your screen. And the image you see is the web page where all these best practice documents are located. Now, Public Health Ontario recently published ORA guidance for clinical office practice along with a fillable form. This document basically walks you through the same process I just did, and it does provide you with the same clinical example I provided in this presentation. And I want to stress that this process is not unique to clinical office practice. So if you are from another setting type, you feel free to look at this resource and make yourself familiar with this process, and feel free to even use this form as well. We are trying to publish specific documents for other setting times in coming days. Our participants from long-term care homes can review this fundamentals document that nicely summarizes strategies to prevent and manage COVID-19. But really, they can be generalized to other respiratory viral diseases. In that document, you can also look at the Appendix A that talks about ORA. So Public Health Ontario has a number of checklists, both of which are developed pre and post the start of the pandemic, specific to different healthcare settings and congregate settings. You can use these checklists as a self-assessment for your organization, and the results can be used to guide policies and procedures, preparedness, and response planning. If you have already used these tools, then this information can come in very handy when identifying and analyzing your risk and prioritizing them. So we have all the links provided in this slide deck, and we will be dropping some links. My colleagues will be providing some link in the chat box as well. Now, audits these help in monitoring infection prevention activities. The results can be shared with the individuals as well as the organizational level to improve the compliance. Audits are another tool that you can use to complement your risk assessment. Conducting audits can tell you a lot about how your organization is performing in protecting the staff, residents, clients, and patients by, for example, assessing how your organization is doing in terms of performing hand hygiene, using personal protective equipment as per recommendations. Audits give you an objective measure of how you're doing and assist in setting the goals for improvement. Audits can also identify what your organization is doing well. There are audits specifically for hand hygiene, and soon the public personal protective equipment and cleaning audits. They are all available on Public Health Ontario website. These links will directly take you them. In the end, I can stress on is conducting an ORA is essential for preventing healthcare associated infections. You can start today by reviewing your infection rates, audit results, or simply conducting a walkthrough and making observation of the activities and interactions and see if they have any risk for transmission of infections. Finally, the key takeaways from today's session are systematically identify, evaluate, and mitigate infection risk, develop and enforce strong IPAC protocols, continuously monitor and update infection control strategies to protect patients and staff. Now, With that, I thank you all for listening to this presentation. I now pass it on to my colleague, Laurie.
Thank you very much, Rohit. And that was a very insightful presentation. So we're going to move now into the Q&A segment. And I encourage all of you to place your questions in the Q&A pod at the bottom of your screen. And we do have a couple of them there for you, Rohit. And there was one question that came up, and Capacity Building has put some links in the chat to the organizational risk assessment and the form. These are for clinical office practice, but someone was wondering if we have something for acute care or if these can be adapted.
So that's a good question. For acute care, already there have been some tools available from PSHSA, and they were actually created in collaboration with people from Public Health Ontario. And this was, I believe, at the very beginning of the COVID pandemic. And we can certainly provide the link later on, but those tools are great. They are quite extensive for hospital settings. Again, this is not a fixed process that you have to follow this or that, but these are different ways you can come to the same outcome. So take a look at that PSHSA website. They have those risk assessment tool, or you can even expand on the tool that we have on Public Health Ontario website for clinical office setting. I did discuss one example of CLABSI today with that can happen in acute care setting, but you can similarly think about other risks and use the same process.
Great, thank you, Rohit. And we will be providing the links in this presentation in a post-session email as well. But thank you for that. And we'll find that link for PSHSA. That was a great document they've developed. So the next question is about data collection, and this person states that it provides great storytelling in terms of how well infections are managed. However, having no data to compare or baseline numbers can make it difficult to see whether protocols are effective or not. And sometimes year-to-year comparisons do not provide helpful data. So this person is wondering, any ideas on how facilities can use data collection as part of the organizational risk assessment?
Yes, I think that's a great idea that, sometimes when you think about making improvements, you do need data. Data matters. So if you don't have that, you can't think of other control measures to put into place, or even evaluating the existing one if they are working or not. So if the first and foremost obstacle is you don't have that number, I think that that is something I did also mention in my slide when we were talking about um, doing some preparation work before you start on this ORA process to have these data collection plans to put into place, or even if you don't have audits in place, then you can start doing some audits. You don't need to sit and wait for the whole year worth of that data to make those decisions. You can start off small. You can review a month or two, whatever, to see how it is going into which direction, and you don't have to wait too long to place the interventions to help.
Great, thank you, Rohit. The next question is from someone who is new to IPAC and works in a community health center. Do you have any resource suggestions for where I can find out more about proper cleaning, training available regarding environmental services and products?
Yes, and I do have an answer for that. We at Public Health Ontario, I couldn't provide a whole lot of resources, but Public Health Ontario has a lot of resources, especially when it comes down to training on IPAC best practices in different areas of cleaning. So not long ago, in I think last year, October, around the same time of the year, we did publish a lot of resources for training in healthcare settings for environmental services. They have about 5 modules in there, and there's also a sixth module that is for the supervisor. Now, in certain settings, it is possible that you are contracting out that services to an agency. They're not employed by you, but you can always have those discussions with those contracted people and discuss about their policies and their products that they use or the training they have received. So it helps you to know that you are receiving the best cleaning and disinfection in your place.
That's wonderful. And I have placed the links in the chat for the for our environmental cleaning resources and the training modules. And Melissa has also provided that PSHSA document. Thanks, Melissa. Next question, are N95 masks not necessary when caring for a resident who has COVID-19 infection? Did guidelines change? And I'm not sure if you want me to pull up, we can provide our PHO document, but
So I will say that this, and then you may have more questions for different settings, and then the question will be like in this situation and that situation. So the best is that just yesterday, I think we published, the PIDAC published the best practices document for acute respiratory infections that also has a section in there that recommends different that provides recommendations for using N95 respirators in different situations. So when you do provide direct care to patients known for COVID-19 or the other respiratory symptoms, you have to use your point of care risk assessment, the level of risk of exposure to them, what kind of activities or interactions will be there. So the recommendations are there, like to wear nicely fitting medical surgical procedure mask, or you can even opt for N95 respirator.
perfect.
So N95 is a choice in many cases.
Okay.
Oh, I see that
There.
there is a document. Thank you.
Yes. Okay, let's see. Someone is asking for audit tools for healthcare staff for ASP. I can provide a link in the chat for our antimicrobial stewardship resources if that helps, Rohit. We're running
Yes,
short on
please.
time.
We do have a lot of tools available from our ASP program. And in due to lack of time, feel free to always email us later after this webinar. So if we are not able to provide you with the link at the moment, we can share more information and put you in contact with the team actually, who can provide you more guidance.
Great. And someone is asking about a webinar for new IPAC leads in long-term care. So we do have a section of our website. We can provide the link to that as well with recorded webinars for orientation for IPAC leads to long-term care. So I will go on to the next question. Is there a guideline we could use to determine how many audits are needed to effectively evaluate, such as hand hygiene, environmental cleaning, donning and doffing, etc.? Should it be based on how many staff, residents? So I'm wondering maybe we could reply directly to this person since this might take a little bit longer to answer, or did you have any
Well,
thoughts, Rohit?
just a quick answer that, there are things like burn calculators available from CDC website, and I think we have a reference to those in our PPE audit tool page. So, you can always look at those. And then in terms of number of audits for anything, like you are looking at personal protective equipment usage, or you are talking about hand hygiene, or you are even talking about environmental cleaning. So we do have resources and a great guide and presentation to explain all those, that how frequently you should be doing. And it depends on a lot of factors: the size of your organization, the number of interactions, and healthcare workers, and also how many, if you do have a lot of patients, residents placed on additional precautions, then you will definitely be running out of those PPEs more. So there's a lot of that information, and it's a very good time to look at this because this will help you prepare for the coming outbreak season. so you have enough supplies in place based on your past history.
Great, thank you, Rohit. And last question, someone is just wanting clarification on the N95 masks for COVID-19. And again, we can provide some links for this in the chat.
Yep, and as I said that we have that document just came out yesterday. It provides you with a little bit more explanation in different scenarios and different types of settings. I recommend that you go and look into that, so that you can find different scenarios helpful.
Great. Well, we want to thank everyone today for joining us for our session. I'd like to thank you, Rohit, for this excellent presentation, and to my co-moderator, Melissa, and hope that you'll complete a brief and anonymous survey that you will receive following this session. And to access today's PHO presentation, review past presentations and recordings, and view upcoming sessions, please visit the PHO website, navigate to Education and Events, and click on Presentations. Thank you and have a wonderful day.
Thank you and have a wonderful day too.